Welcome, everybody. Good morning or good afternoon, depending where you're connecting from. Welcome to this new virtual dialogue from UICC. My name is Alessandro Di Capua. I'll be introducing a little bit of logistics to start with before passing the words to our expert for today's sessions. So today is the second virtual dialogues in our Cancer Beyond COVID-19 series, which we started 2 weeks ago. So today is about bringing quality cancer care closer to patients. And we have a group of panelists and our moderator who will start the conversation, but we also very much look forward to hearing from you. As usual, these are dialogues and we stress the word dialogue. So we very much look forward also to hearing from your perspective and your insights. And I also would like to thanks our supporters that made this series possible: MSD, Novartis, Pfizer, and the Canadian Partnership Against Cancer. So a few ground rules. You probably been living in Zoom for the past year, so you know all this very well, but there's no harm in repeating. Unmute yourself only when talking. So if you're not talking, please stay mute so we minimize any echo and any disruption. Feel free to have your camera on if you so wish, unless there are issues with the connections. As I said, we really like this to be an interactive session, so make full use of your chat box. Please open the chat box, open your participants list, and as you hear from the speakers, feel free to use the chat box to introduce yourself and also to post comments and to start posing questions, because we will get back to them in due course after having heard from the panelists. As we would like to engage with you, also feel free and at the right time when we move on to the interactive part of today to use the raise hand, the digital raising hand tool that you can find by switching on, by opening the participants box. So just a very quick look at what we're going to go through today. What's our agenda? So we split this sorts of conversation in two parts. The first one, it will be an expert-led discussion, and it will last for approximately an hour. We'll have a setting the scene presentation and a panel discussion and a Q&A. So during this time, we will also hear from you, but the conversation will be led by our expert panelists. As I said, feel free to use the chat box to add your comments and to add your perspective and questions during this time. The second part, which will last approximately 30 minutes, is what we really like to bring you in the conversation. So we will have an open question for all of you, and now I'll show you a little in a little while how you may be able to answer, and an open discussion. So hopefully many of you will be also willing to share their experience verbally as well as in writing. Now, before I just pass the word to our moderator for today, as I mentioned, we will be using menti.com to get some of your input. So just to get a little acquainted with it, we thought we can start with a very simple question today. So if you simply go, you may use if you have a smartphone handy, it might be useful to do it from your smartphone, or also feel free to use a computer. If you go to menti.com and enter that code, 4202057, well, I'd just like to invite you to share with us in writing, what would you like to get out of today's dialogues? Whether it's connection with peers, whether it's a particular aspect of the topic we'll discussion, anything you like to get out of this, please type it on this open question that you find it on menti.com using that code. We will be using this tool also to gather some more insights later on, so we thought it'd be quite good for you to get acquainted to it. We will come back to your answer to these questions at the end. Maybe I'll just look in a little bit at Sinead to see if we have any answers coming in, because it may be also interesting to share some of the perspective and so what the participant would like to get out of that to start us off, to have a little sense.
Yeah, we're getting a few responses in. I can share the
Perfect.
screen quickly if you like.
Please do. I'm going to stop sharing now.
Can you see my screen? So
Yes.
you can see people are looking for new ideas, expert advice, and examples of good practices, learning about the impact of COVID-19 in cancer from global perspectives, especially as we've heard mainly from high-income countries. So maybe some focus on low middle income countries will be appreciated. Let's see, dialogue with participants, that's something we really want as well. So feel free to contribute in the chat, to contribute your experiences as well, because that's one of the best parts of these dialogues.
Fantastic. Well, that seems all very relevant. So feel free to keep answering the questions. We now move on past to our moderator, because we'll come back to this and we'll try to make sure that we've covered at least some of it, or if we can do it also following this conversation. So, and now, without any further ado, I'll probably pass the word to our moderator for today, who is Kirsty Graham, Director of Capacity Building at Union for International Cancer Control. Over to you.
Hello, everyone, and welcome today to this virtual dialogue and to the second in this three-part series, Cancer Beyond COVID-19. And this series is really around exploring the changing landscape of cancer care and looking at what we've learned from the last few months, or the many months now of the COVID-19 pandemic, and really looking at how we can use this learning to shape the future. And we really wanted to have this discussion as part of this virtual dialogue series to really explore and reflect with our members, our partners, and the cancer community on the adaptations and the changes we've seen over the past few months, but also to highlight and discuss which of these trends, which of these innovations, which of these actions could actually be long-lasting and could help us to transform the cancer care kind of services and cancer control in the future, and how we can create more resilient, stronger, and equitable health systems. So I first just wanted to highlight that over the last few months, we have had a number of very specific dialogues looking at the challenges faced in delivering cancer care during the pandemic. For example, we had one around caring for older patients during the pandemic. And I would recommend you to go to the UICC website to look at the past dialogues resource hub, where you can find recordings of all of the dialogues with additional resources and materials. So if you've missed any of them, you want to recap on any of those topics, please do go to the website and have a look. And before we dive into the topic for today as part of this second series, I just wanted to give you an overview of a few points that came out of the first dialogue in this series, which was focusing specifically on reimagining cancer screening and diagnosis. And we had representatives there speaking from the Canadian Partnership Against Cancer, Cancer Research UK, Novartis, and Tata Memorial Hospital, India. So we had lots of different contexts and experience represented on the panel. And I think it was very clear from the discussion that there were a lot of shared experiences despite the different contexts. We obviously saw a reduction in screening services, deferral of diagnostic work, a backlog of unmet demand, and a lack of capacity, and many challenges and difficulties were shared. However, what I personally found quite inspiring from the discussion was that nearly all the panelists talked about the silver linings that we could see in these challenges, and things, a number of things were highlighted that I just wanted to share with you now. So one of them was around accelerated decision-making processes and the adaptability of the health system, what they had seen both in cancer care, but also in COVID, and looking at to see how we could harness this momentum for the future. Also an increase in innovation and collaboration, and bringing quality screening closer to home and to the patient. And it's particularly relevant today as it's the launch of the Global Strategy for Cervical Cancer Elimination today. They were talking about the self-sampling HPV tests, which are becoming available and which enable access to cervical cancer screening. So they were just a couple of the points that came out, and I'm really excited to moderate this panel today. I think it's going to be a great discussion. And I would first like to introduce Professor Rifat Atun, Professor of Global Health Systems at Harvard University, who's going to do a brief presentation for us to really set the scene for our discussion today and look at the context that we are talking about.
Great. Thank you very much, Kirsty, and a huge thanks to UICC and congratulations for organizing these dialogue series, which are sort of critically important for experience sharing. I'm going to briefly talk about the response to cancer care as part of COVID-19 response. What we have seen, and I think we should be honest about this, that with COVID-19, well, today we have 55 million cases and more than 1.3 million deaths. And these are just reported numbers. The real figures are far higher than these, I'm certain. But in many health systems, the response has been ineffective, has been inefficient, has been inequitable, and responsiveness has been inadequate. And we now see that North America, Latin America, and Europe are the epicenters of the epidemic. And these are in many countries that have traditionally had fairly successful or high-performing health systems. But actually, health systems were long in decline. And I think we knew that, but we've not been honest to discuss this. But the sheer magnitude of the underperformance has been unmasked by COVID-19. These are two studies we published in 2019. One's looking at management of hypertension in 44 low and middle income countries, and another looking at management of diabetes in 28 countries. And this looks at cascade of care. Again, this is using individual level data with biomarkers, so very reliable. And more than 1 million patients or individuals or respondents. And in Latin America and the Caribbean, hypertension control is just about 20%. In Middle East and Central Asia, around 10 to 12%. But in South and East Asia and Sub-Saharan Africa, below 10%. For diabetes, the control in the 28 countries we studied was 30%. So, I mean, this is huge underperformance. So the question is, how were we doing in relation to cancer before COVID-19? And we recently estimated as part of the Lancet Oncology Childhood Cancer series, we were able to demonstrate the huge differences in the 5-year net survival for diagnosed childhood cancers. As you can see, reaching 80 to, well, more than 90% in the US, in Canada, and in Western Europe and Australia, but actually very low survival levels in many of the countries of the world, specifically in Sub-Saharan Africa. And we are able to estimate that 1 in 2 childhood cancer cases are missed in the world. And our modeling suggests that in 2020 to 2050, there would be 13.7 million new cases of childhood cancer, but at current levels of health system performance, 6.1 million cases would be missed. And as a result, 11.1 million children with cancer would die without new investments to scale up. But if we do scale up, for example, in treatment, in chemotherapeutic treatment, radiotherapy, surgery, as well as quality of care and interventions to improve adherence, we see a sort of sharp decline in annual deaths and sharp improvement in 5-year survival. And the net benefit is huge. The cost of this is around $590 billion, but the benefits exceed $2.5 trillion, and the net benefit is $2 trillion in the 2020 to 2050 period. So with innovation and scale up, it is possible to address these huge inequities that exist. And this is not just for childhood cancers. There's also huge differences in survival. And this is a paper published a few weeks ago in Lancet Oncology, where we modeled for 11 major cancers 5-year net survival to show very big differences for these 11 cancers between high-income countries, upper middle-income countries, lower middle-income countries, and low-income countries. Huge differences. But again, our modeling suggests that with increase in quality of care plus treatment, this chemotherapeutic treatment, radiotherapy, surgery, quality care, and the scale-up of diagnostics, comprehensive scale-up, one can achieve very substantial improvements in 5-year nurse survival, where low and middle income countries can converge with those levels achieved in upper middle income countries, and not that far from upper income countries. So there's an opportunity. But then comes COVID against this background. What COVID has done is it has really impacted on the services, and we were not prepared. We knew COVID was coming, or a viral infection with pandemic potential was coming. We just didn't know when. But health systems were generally poor prepared. In relation to cancer, we see declines in screening, declines in diagnosis, reduced access to cancer care, foregone care because people are scared to go to hospitals or cancer centers, or delayed care, or when people do reach these centers, suboptimal care because we're not able to operate freely. And this has led to increase in the number of undiagnosed cases, late stage presentations, increased morbidity, increased number of deaths and costs. And there's some modeling studies that are suggesting huge excess morbidity and mortality as a result of the interruptions to care that I have outlined. But COVID-19 has also accelerated, Kirsten, as you've said, use of innovations for better care. And so there is hope. So we should not let this crisis go to waste. We should really harness these innovations and leave behind the past, which clearly was not fit for purpose, given the performance level that we're observing. I think we should be very bold in our ambitions going forward. We're seeing increasing use of diagnostics and therapies for personalized care. We've seen with COVID-19 harnessing big data and AI to deliver better decisions, use of conversational agents such as chatbots or chatbots with artificial intelligence, even in some settings, use of robots where person-to-person care was not possible. We're seeing really an explosion of really great examples of remote diagnosis and remote care, and increasing use of wearables and smartphones and sensors to monitor real-time health data. So all of these innovations exist and they're scaled up in some settings, but not to levels that would make transformational improvements and address the pent-up demand that is there for cancer and that is going to get worse. So what do we need to do? Well, going forward, we need to transform the way the health systems function. We really need to harness the possibilities and these innovations that exist. And for that, we need to invest in people. We need to invest in partnerships that bring together civil society, that bring together patient groups, that bring together both public and private sector, because all of us have an opportunity to contribute to the new post-COVID-19 world. We need to use the existing platforms, but invest in specifically in digital platforms and platforms that enable more efficient and effective care delivery. And finally, we need politicians to ensure that they develop the right policies to create this enabling environment. But I'm hopeful. Let's not waste this crisis, and let's use it as an opportunity to harness innovations. Thank you.
Thank you, Rifat, for that inspiring presentation. It's definitely been a challenging few months, but it's great to see that there are many, many things that we can harness and learn from this experience to take forward. I'd now like to invite some of the panelists to share their perspectives from their own context, some of the experiences they've had in recent months, and some of the innovations and opportunities that they're seeing from their different contexts and different expertise. So I'll introduce the panelists and then invite them one by one to share a few of their thoughts before we answer some specific questions. So first of all, I'd like to introduce Miriam Mutebi, who's a consultant breast surgical oncologist at the Aga Khan University Hospital, Kenya. She's also a clinical epidemiologist and a health systems researcher. And then I'd also like to introduce Rocio Sáenz, coordinator of the Permanent Forum on Cancer in Women in Costa Rica, and also the former Minister of Health of Costa Rica. And Philippe Drouet, the Senior Vice President of Global Oncology at MSD. It's fantastic to have you with us, and I'm really looking forward to hearing your thoughts on Professor Rifat's presentation, and also bringing your own experience and expertise from your specific areas.
And
Miriam, yes.
Kirsty, I should add, Costa Rica is an outlier. It's a high-performing system. So credit to Rocio for her leadership.
Fantastic. Well, maybe then, Rocio, we'll start with you. That's a fantastic introduction. Thank you, Rifat. Rocio, would you like to take the floor?
Yes, thank you. And thank you, the comment for Professor Rifat. I am very pleased to be here and share the experience of my country. And of course, try to learn all together, because these times is telling us that we have to work together to build each day better health system, and of course, improve the quality of life of the people. I think it's important to let you know that Costa Rica has a very special health system. Our health system is more universal health coverage, and of course it's based on primary health care. That means that we have a very broad coverage for the most of the people, more than 90% of the people. And our health system is financing by the contribution from the employees, the workers, and the states. But of course, the COVID-19 arrived in our region. Our region is our Latin American region is the most inequality, and our health system, most of the countries are very fragmented and segmented health system. But today we're talking about the Costa Rican experience. And we have in Costa Rica a project that we call the navigation. And this navigation project is coming with, we are working with from the academia, the NGOs, and also the health services. And we try to build the experience of the patients, especially from the breast cancer. We built a database, a nominal database, since the people, when the women start with the diagnosis with the cancer. And after that, another survivorship, women that they has the experience and survivor of the cancer, bring the support and call them and try to share the experience and to take from the woman the voice of their own experience, and with the professional in the health promotion, that is a new career in Costa Rica. This new professional built all the barriers that the woman match in the health system, and then we try to management. With the COVID-19, we have to go to reinvent our project and go to the virtual way. And this is very important, because our volunteers are people that are working at home, and they need, of course, to develop how to use this kind of platforms to work together. And what's very exciting, how to training them, and of course, how to try to understand how the distance can affect the delivery of the services. We found that the very important solidarity from the woman, and how they try to take the eyes in this kind of platform, how to take the sense of the experience of the patient, in this case of the cancer patient. And right now we have 88 volunteers working at home, and they are on pay. They are given the time to work with the health system. We bring to the health system all this information, and the oncologists, the nurses, and the different providers are learning about the experience of the woman at home and try to adapt the services and to be more comfortable and keep the continuous of the treatment. Of course, as Dr. Rifat said, we have some effects about the COVID-19 and how the woman afraid to go to the hospital, and has, of course, interruption for the continuance of care. We believe that we can work together with this NGO, the academia, and the health services, and provide the voice from the woman, the experience from the woman, and how we can allocate the patient at the center of the health system. And this is always will be a challenge for any health system, but also we recognize that we have to work together to go in this way. This is my first thoughts on that.
Thank you, Rocio. I think the importance of the patient voice, patient-centered care, it's definitely something is coming up a lot recently, and perhaps now is more important than ever as we look to rebuild or to strengthen the health system as we move forward. The other point you raised around shifting to a virtual model of care, clearly that is also important. I'm sure that will come back up in discussion in the discussion to come. Miriam, would you like to share a few initial thoughts and perspectives?
Sure. Thanks, Christy, and thanks to the participants for this opportunity to share. I think, Prof. Riet's given an eloquent, I would say, introduction and setting the scene, and I think trying to ground us to the key fact that, in the middle of, adversity, there is opportunity, right? And I think one would say prior to COVID, at least in sub-Saharan Africa, we were saying it was probably an exciting time to be as part of the cancer control, just because we've seen more than an exponential increase in the number of countries just within the last 10 years that have come up, with national cancer control plans, and there is, an increasing awareness and drive, especially around, looking at models that would help to generate universal healthcare coverage. Certainly in many parts of Africa, for instance, Kenya, Rwanda as well, they have been, trying to have models that expand services around, certainly in Ethiopia as well, trying to look at how we can build in universal healthcare coverage and incorporate cancer care as part of these models. Now, I think we were a little late to the party in Africa, where we sort of just saw the major hits, I would say, occurring specifically around April, May, which is when, of course, there have been a lot of widespread numbers of patients internationally. And I think the first reaction, as I think was happening across the world, was a lot of fear and uncertainty, especially around the diagnosis and what to expect. And, following the dire predictions, people were saying that this is going to be, Africa is going to be really hard hit. And so as a reaction to that, quite a number of countries enforced lockdowns, where patients were not able to travel, were not able to access care. And what we initially noticed with the lockdowns was, again, our numbers were not as high. They're still not as high as anywhere else in the world, but they are, steadily going up. So we can't ignore that as well. The other issue is that we were seeing more of the downstream effects of the the lockdowns, in the sense that we were not having as many patients initially, but because of the lockdowns, a lot of financial insecurity, people were losing their ability to access care. People were not able to, either if they were on treatment, they got their care disrupted. And what we also saw was, in losing their jobs, they were then losing their financial ability to pay for care, because keep in mind that at least certainly in most parts of sub-Saharan Africa, patients frequently have to pay out of pocket for their health care, and this routinely results in on occasionally in catastrophic health expenditure and financial toxicity, and then now add to that the fact that you're jobless. And so we sort of saw a disruption of all the, I would say, non-COVID related services, because we saw, for instance, an increase in infant mortality, increase in maternal mortality, and definitely looking at cancer care. Again, screening on its own is opportunistic, but then now we were having that further impaired, and then having to triage. As a surgeon, we had in certain number of countries, they closed off the cancer surgeries because there was a confusion around, is it elective, is it emergent, is it semi-emergent, where do we put it, do we stop? And so there was quite a backlog of patients. And just because of the fear and uncertainty, there's a lot of concern around will patients actually get care? And we're currently seeing patients who've had their lumps all the way from February coming in now, because I think the narrative that was going around, and not just, I think, locally, on a international perspective, was, I mean, the message that patients were getting is, you go to the hospital, you get COVID, you die. And so that's one of the things that we've sort of had to think about, even in terms of managing what are the opportunities to see how we can deliver care still within all this and going background of whatever else is going on. And the first thing that we had to shift very rapidly is looking at how do we still manage to maintain contact with the patient. Now, one of the first things that we had to do, especially in certain parts, I can give at least from the Kenyan example, is we had to rapidly figure out how to strengthen our navigation, patient navigation programs, especially in the public sector. And looking at, these are patients who were routinely coming in and maybe were not able to access care. So we've had to look at what models fit best, and we've had to broaden our patient navigation, our oncology nurses, and expand their role in terms of following up and trying to keep patients within, or at least just maintaining the contacts to actually show the relevance and importance of continuing with their care. And of course, also the reassurance that, you know, you would still be able to receive your care. The other thing is, for patients who we've not been able to reach, or who've not been able to travel due to lockdowns, we've had to come up with telemedicine models that work. But keep in mind that these are mainly in the context of urban settings, or patients who have the privilege, for instance, of having, you know, network and, you know, connectivity concerns, because and that doesn't necessarily reflect you know, a broader majority of patients in sub-Saharan Africa. We've also had to look at what are kind of models that we can have where we can deliver care to these patients. And so we've also had to come up with mobile pharmacies that can actually deliver the drugs. But as I said, this is just the tip of the iceberg, and there's definitely many more thoughts that I just want to give everyone a chance to reflect. But I think those are my preliminary thoughts as we start this discussion. Thank you.
Thank you, Miriam. Yeah, we're very aware this is a very rich discussion, and there's a lot of different areas that we can focus on. And I think there's a lot of important points that have been made already. Yeah, looking at different models for telemedicine, the importance, as I said, of the patient voice, patient navigation programs. One of the points that was raised in the last dialogue was about restoring patient confidence in services. I think these are all very valid points. And I think just to come back to Rifat's presentation, and he highlighted four key pillars of our, you know, as we move forward, of our response, and people, partnerships, platforms, and policies, all very it's a very helpful kind of grouping of the different areas of importance. Philippe, I'd love to invite you to share a few of your initial thoughts on the comments so far on Rifat's presentation from your own experience.
Yes, hello, Kirsty. Thanks for the opportunity to participate in this this discussion this morning. You know, we at MSD, which is of course a research-based company that focuses on oncology and innovation oncology, we're working with hospitals around the world on research to develop new therapies, innovative therapies for cancer care. And just as Dr. Atun has mentioned, we've also noticed in our interactions with those, with our partners, with those hospitals around the world, that there's been a dramatic decrease throughout the year in screening, in diagnoses, but also in treatment of patients. And so, Dr. Atun, I mean, our own observation within our company, and this is based on sort of direct observation by MSD contacts with cancer centers around the world, is that data that you shared is very much a reality in the majority of countries around the world. And so it exposes the fragility, doesn't it, of our cancer care system. And it means that, you know, some outside threat like COVID-19 can disrupt the care for thousands and perhaps even millions of patients around the world. And hearing from Dr. Mutebi and Dr. Science, you know, there's lots of great kind of efforts that are being made to try to overcome this challenge and make sure that we can still get cancer patients the care that they need, even under these challenging circumstances. You know, I'd like to share one or two examples on a positive note as well of some of the things that we've learned at MSD and in industry in terms of how we can collaborate with government, with payers, with our partners in the cancer centers in order to, to address the situation with some innovation. And so the first example is earlier this year when we saw the issue with the pandemic accelerating, and we understood, as Dr. Mutebi had pointed out, that there was a situation where patients were hesitating to go to the hospital. In some cases, even if they were diagnosed, they were hesitating to go to get their treatment because they were afraid. And also, hospitals were struggling to cope with the situation. So we actually had developed a new formulation for one of our most widely used cancer medicines that allowed for less frequent visits, but with the same treatment outcomes. So instead of a patient going in every 3 weeks to receive their infusion of their medicine, they could go in every 6 weeks and get infused and get the same benefit. But this innovation had not been approved by regulators. It was something that we had been working on in our labs, but was not yet approved for use. So we approached regulators around the world and proposed that it may be important to approve this new treatment regimen in order to relieve the pressure on the cancer centers by having patients go in less frequently, without compromising, of course, their care, right, and the benefit of the treatment. And the wonderful outcome of this story is that regulators embrace this. And for example, the FDA approved this new formulation in 3 days, which is the fastest regulatory approval that our company has ever received for any submission in our experience with oncology. So, and then we were able to communicate using sort of teleconferencing techniques and without any face-to-face interaction, without visiting the cancer centers, we used other methods of communication to communicate quickly to all the cancer centers the availability of this new treatment option. And the uptake was very fast. So this is a great example of how it's possible to collaborate between a research-based company and regulators and government, and also oncologists who are actually treating the patients in cancer centers in order to quickly react to challenges that are affecting cancer patients and bring a new solution, literally within a few weeks to cancer patients. So with the right mindset and a sense of urgency, I think it's possible for different stakeholders to collaborate and really make a difference quickly in terms of the care that cancer patients can receive, even in the face of a crisis like the COVID-19 situation. And so, there's, I think all of us can probably share more examples of how collaboration between different partners in the healthcare system can really make a difference. And it's certainly one of the points that I wanted to emphasize today. But I think also all of us need to take another lesson from this, is that when there's a sense of urgency around the need to care for patients, as there is now for patients affected by COVID-19, I think that we can see its enormous mobilization around public and private and different stakeholders, being very creative in terms of how they work together, and in a way forgetting about all of the kind of the barriers or protocols that govern, and slow us down. I think that there's a lesson to be learned there in terms of how we are all working together to address the COVID-19 challenge. And can we bring that same spirit and that same sense of urgency where we involve all stakeholders working together, but with a mindset of urgency in order to address this situation for cancer patients? And I'm talking about beyond COVID-19. I'm talking about the global emergency that we have with just the sheer number of people who are affected by cancer around the world. Let's try to communicate the same sense of urgency for cancer as what we have now for COVID-19. I'll hand it back to you, Kirsty.
Thank you, Philippe. Yeah, some excellent points. And it reminds me actually of the press release that's gone out today about the cervical cancer elimination agenda, where Dr. Tedros it includes a quote which speaks not only of the innovations that we have available to treat and to prevent cervical cancer, but the fact that we need unrelenting determination to really drive them forward and to scale up these innovations. And it was fantastic to hear also of the acceleration of decision-making processes, which is actually one of the points that came out of the discussion in the last dialogue. And it's great to hear that, this is something that's happening in terms of cancer treatment as well. And also obviously collaboration, which is so important. Miriam, I wondered if you wanted to comment at all on whether you've seen in terms of the impact on patients in terms of alternative treatment regimens like the one that Philippe just mentioned in terms of clinical care. How has this been received by patients? Have you, what evidence is there around that, and how has that been accepted or received in your context, whether it's specifically about that treatment or another?
Thanks, Christy. I think one of the I would say the silver linings is that we've become more connected globally. I mean, just the fact that we're having this conversation, this dialogue, is a clear testament to that. And I think from a health worker perspective, I think health workers have been more receptive to combined and shared learning, especially around things like, say, the few radiation services, for instance. And there was quite a bit of, there is good evidence supporting hypofractionation of radiation, of radiotherapy, where you're actually having, larger doses and less visits. And I think for the longest time, there's a bit of reluctance or for a couple of reasons to embrace that. But as a result, we've seen that this has led to more people sort of thinking critically around how can we optimize, patient time and travel. If you're having to sort of travel back and forth, can we give you a larger dose at a shorter period? And of course, that probably has been well received by most of the patients who are having to cut down on their time for travel. Of course, what has also happened is, again, there is, as you said, part of the pressure or the acceleration of decision making, because part of the concern from a policy perspective is that I mean, there have been efforts around, trying to decentralize some of these services. For instance, in Kenya, you'd only be able to access initially radiotherapy services in the capital, but now the government has been, looking at plans to decentralize, and this suddenly has brought a sense of urgency, because how do we then get, this care a little more accelerated? From a patient experience, interestingly enough, and again, this is not as widespread as we would like, but I think patients' preliminary sort of feedback from the patients is that they actually preferred it more, especially the telemedicine, which was a little counterintuitive to us. We thought, maybe perhaps the physical in contact care would probably work better, but a couple of patients sort of reported that, listen, when I'm with, on a telemedicine call, the oncologist actually has a little more time for me, because we sit and we talk a little more, and so they actually appreciated that. And even with the patient navigation, I think it's all about patient support and connectedness of care. So the fact that, even as a navigator is calling you to say, hey, how are you doing? How are you feeling? I think that's been incredibly helpful. And I think those are certainly some of the practices that we do need to continue going forward, irrespective of what's going on. Just that, constant dialogue with the patients, as Maria was talking about, just that, getting the patient's voice heard and addressing those concerns. I think those will definitely go a long way towards optimizing care. Thanks.
Thank you, Miriam. Yeah, I actually, I was reading the other day that there was a large survey done across a number of countries, mainly high income, but a number of countries where there was 90% of patients it wasn't just cancer, but non-communicable diseases, felt that their care was as good or better than before. And obviously it's just a snapshot, but it's interesting to hear your experience as well, that actually patients can find this new way of delivery actually perhaps in some settings and for some services more acceptable. Rocio, it'd be great to bring you into the conversation here. You mentioned a lot about your work in terms of patient navigation, and it would be great also to hear about the perspective of the patient in terms of how they have received some of these transitions in terms of the new models of care.
Yes, thank you. I'm sorry, I was in mute.
Don't worry.
I think in our experiences, it's very important to take the knowledge from the patient, but also the sense and how this kind of information fit the medical records. And I think this is not only to take the voice, it's also how to take this voice, and this voice change the way that we are delivering the services. And I believe this is one of our challenge before the COVID-19, during the COVID-19, and after. And I think we have to really take in mind this, especially if we are talking about the continuous of the treatment of the patient cancer. I am including the palliative care, because sometimes we are focused only in the treatment during, but also we have to take in mind how this COVID-19 change the way that we are delivering the services, the continuous of the treatment since the prevention and health promotion to the palliative care as a continuous. And I think we have to really build the information to fit the delivery that the health system has to provide. And also, if I have an idea from Philip and Dr. Griffith, I think one lesson learned from the COVID-19 is the money is going to investment to find a way to approach the COVID-19. And for that, I think it's important to hire the voice for more money for the health system, but also to spend better. I think we need to more money, but also to find a way to allocate, demonstrate, and look for more effectiveness, not only efficiency. And for that, I think it's the time to take the effectiveness of our health system and how to build the indicators that really we are improving. And we learned from the past, from now, and for the next generation to bring them a health system with a better performance. And for that, when we are talking in the forum with the women with cancer, they are telling us they need really feel more comfortable, be part of the treatment, knows more about their own disease and how they can, of course, be part of the treatment, not only give this responsibility for the health system. Also, the patient needs to go and be more empowerment for how they can improve the quality of life during the cancer process.
Thank you, Rocio. Just at this point, I'd just like to thank Rifat for his contribution, his presentation. Rifat, I wondered if you actually had a few comments on Rocio's points there about building, using cost-effective interventions, building the health system. Rifat unfortunately has to leave us in a few minutes, but we will be continuing with more questions after. Rifat, I'll hand over to you.
Yeah, thank you, Kirsty, and really great comments by Miriam, by Rocio, and by Philippe. And I fully share their sort of vision of transforming health systems and also looking at ways of overcoming bureaucracy that has actually hindered adoption of innovations. There are many innovations out there, but they're just not taken up. And I think COVID-19 is a wake-up call. And we've seen many examples of new approaches that has been able to enhance patient experience. I think what's important, as Rocio said, is that we need to think, we shouldn't just invest in the health systems as we've done in the past. Because, as Einstein said, madness is doing the same thing over and over again and expecting better results. That's just not going to happen. In fact, many of the studies we've been doing have been looking at the effectiveness of health systems, the performance. For example, the care cascade I've shown for management of diabetes, hypertension. And we've done this for cervical cancer. We've done it for many conditions. And consistently, we're seeing terrible underperformance. I mean, we're not talking about 1 or 2 percentage points. These are very substantial underperformance, 20–30% control. And the studies we've done that looks at survival, survival is a very good marker of performance and effectiveness of care, because it is the whole experience of the patient that tells us what's happening in the care process. There's huge variability both between and also within countries. But we can improve and we need to improve with new investments, equity, efficiency, effectiveness, and experience of patients. So we need to invest in the right things, do them in the right way, because there's huge amount of waste. 20 to 40% of healthcare expenditure is wasted. We need to ensure that we deliver care to the right people, and we do this in a responsive way. So collectively, it's not just one or the other. It needs to be a comprehensive approach. And as we've shown, actually now in 3 commissions, the first, the Lancet Commission on Radiotherapy, that we can scale up interventions. And this provides very high return on investment. And we've shown with Lancet Commission on Childhood Cancers that investment in cancer the scale of cancer interventions is a very good investment. And now with Lancet Commission on diagnostic imaging, which will be out very shortly, we're able to show massive health benefits, but also we'll be able to show good return on investment. So I think the opportunity is there, but we need to change our mindset and let COVID be an opportunity for us to do that.
Thank you, Rifat, and thank you for being with us today.
Thank you, and thank you, Thanks to UICC, and great to be with the outstanding panelists.
Can I just say thank you, Dr. Rifat? Thank you so much. I loved your presentation. It's really put everything in perspective. Thank you.
Thank you. Thank you very much.
Dr. Hadi.
Thank you, Dr. Hadi.
I'm conscious there's quite a number of questions on the chat. I'd actually first just like to pick up one point that Rossio made about palliative care. And I may be putting him on the spot, but I saw Eric Kabisa on the line from the Rwanda Hospice and Palliative Care Organization. And I just wondered actually if you could, I saw a few articles around the work that you're doing at the moment, and I just wondered if you were on the line and would be willing to share your experience. Not sure if you're still here. Okay, maybe not. If not, we'll hand over to Alessandro, who's going to pick up on a couple of questions that have been posed in the chat. I think there's some great questions that have been asked.
Thank you, Kirsty. And I might invite, actually, rather than me reading the question, I might invite the people that post some of the question. Also notice somebody with a raised hand, so we'll call upon them pretty shortly. So maybe Arun Kumar, there's a question you posed around practical examples of the use of AI in big data. Maybe you would like to ask yourself.
Yeah. Hello, everybody. I'm Dr. Arun Goyal. I am a surgical oncologist in New Delhi, India. So we are seeing a lot of application of personalized care in oncology on a day-to-day basis. My only question is how these information from this research in personalized oncology, AI, big data, how will it help us in the setting of a pandemic, say like COVID-19 or any such similar challenge that we face?
Would any of the panelists like to respond on that point? Maybe Miriam, Philippe?
Kirsty, perhaps I can.
Yeah, please do.
I can say a few words about this. Thank you, Dr. Arun. You know, this is a great new opportunity now to use AI and these kind of advanced data analytics in order to improve the treatment of cancer patients. I know that a number of different hospitals and companies are working on many innovations in this area right now. I can maybe share just briefly one example, something that my company MSD is working on with a number of partners, including a network of hospitals in different countries, is the use of AI in order to analyze the data that's in the electronic medical records of patients, for example, from their screening results and other data that's entered. And what the AI does is it looks for patterns in terms of which are the data points that would point to an increased risk for certain cancer types. Based on a combination of different factors within the patient's, chart, and this gives, and then the AI gives, let's say, hints to the doctor, the treating oncologist, to run additional tests or to investigate additional risks for that patient for certain cancer types. And what we found is that this approach using AI can increase the chance that that patients will be properly diagnosed, or that other cancer risks that the patients may have will be identified and can be treated earlier on at early stage instead of when the disease has metastasized. And so this is one example. And these approaches using AI, we think will be ready to roll out more broadly in hospitals, within the next few years. So this is coming. This kind of technology is at the threshold now of being used more broadly around the world.
So can I say that this approach would be used to prioritize patient care in the setting when the resources are limited or when there's a pandemic putting pressure on the healthcare system? Is that how we would use?
Maybe if I can just comment briefly
Yeah, please do,
on at least some of the users or potential in the setting of low resources. There has been a lot of interest around developing telepathology services, and this being in recognition of the fact that, you know, there's few pathologists, there's lots of pressure towards the diagnostic. So there have been, again, ongoing developments around, are we able to sort of, you know, have pattern recognition where you're actually feeding the slide into the microscope and having, you know, several pattern recognition, and then supplementing that, you know, with a pathologist where necessary. So, I mean, these kind of studies are ongoing currently. There's also been interest in sort of using virtual simulation for surgery. Certainly, there's been work by Grosbeck Parham in Zambia looking at how can we, again, you know, train, even because we have to think about in the absence of, in-person trainings, are there models that we can look at how we continue to develop these skill sets amongst health workers? So they're looking at simulation and using virtual reality to see whether that can have help to train or improve surgical skills, especially as far as cervical cancer management is concerned. So, I mean, those have been, I would say, a couple of ideas. And then, of course, there's work around guideline, not just development, but implementation in low resource settings. You're probably aware of the harmonized guidelines. There've recently been a couple of NCCN guidelines for sub-Saharan, harmonized guidelines for sub-Saharan Africa. And so what there's been ongoing work with IBM to sort of look at how are these models working, at least with clinicians to sort of, you know, feed in an algorithm and sort of look at the management and then give reference materials that are also, more importantly, available offline that they can actually use to better manage patients. So there's lots of, I would say, interest and lots of pockets of ideas. But I think the caveat, even as we think of innovations, is, I mean, they're not a band-aid for dysfunctional systems, right? It does need to go hand in hand with strengthening what gaps they are in the system. And in terms of efficiency, just looking at, you know, we're saying there's a lot of waste and inefficiencies in the system. Part of, I would just like to draw your attention to the lots of choosing wisely initiatives that have happened, I think, in Canada. ASCO has one. There've recently been one in sub-Saharan Africa. And this is looking at, you know, trying to pretty much minimize harmful practices that, or wasteful practices that clinicians are doing. And we're saying resources are, you know, limited right now. So how can we prioritize? We're saying patients, for instance, don't necessarily need to have routine CT scans every 3 months to make sure that, you know, their cancer hasn't spread, right? So they don't need to fundraise. You don't necessarily need to do tumor markers as part of routine, follow-up of patients. So all those kind of measures are some of the strategies that we need to think creatively about. Yes, innovations are great, but we do need to, it does need to go hand in hand with actually strengthening the actual system, because once you make a diagnosis, great, but then what happens? What's that patient's entire journey? So if we're able to get innovations to support the entire patient journey, then that's a win for the system. Thanks.
Thank you, Miriam. Rocio, I saw you had a comment you wanted to make.
Yes, thank you. And thank you to Miriam to remind me about the experience here in Costa Rica, that we have a team with the rehabilitation with breast cancer, and they are building the protocol how to bring the rehabilitation from breast cancer at home by tele-rehabilitation. And this is a very important way how use the technology and how to train the professional, but also how to train the women and the parents that if they need the company to doing this treatment. And I think this approach is going and jump from the COVID-19, the needs, how to follow up the people that who take the surgery, and after the surgery take with some protocols and some guidelines to select the women that they will need to go with this tele-rehabilitation. Of course, we need that the women have internet at home, have at least one smartphone, and of course, how to report how they feel. And I think there are the challenges that we are facing right now, and how to bring together all this information to improve the quality of the health services that they are bringing by this way. And thank you, Miriam, for your comment, because it was reminding this important issue.
Thank you, Rocio. I think you've made a lovely point there that actually was something that came up in the last discussion around we need to be careful. One note of caution about these new innovations is making sure that they don't create new inequities. For example, the ones you raised there about digital inequities and the ability of individuals to access some of these new services that are being provided. Philippe, you had a comment, and then we'll take one more question after that.
Yeah, I agree with Rocio and the point that Miriam was making as well. I think all of us understand that we need to get the fundamentals right first, right? And so there's a sort of a foundation which has to be built in terms of cancer care. And I think first we need more robust cancer care workforce. In many countries, there's only, I mean, many of you know the statistics, right, better than I do, but in many countries, we have only one oncologist per 5,000 people population. And so there's an opportunity to invest into a more robust workforce and to strengthen infrastructure. There's some great initiatives like, for example, the City Cancer Challenge, which is again a collaboration between many different groups, including industry, but also cancer hospitals in a number of cities around the world. This is all about also building fundamental or basic infrastructure and systems, right, in order to be able to provide the high quality basic cancer services. If we can just get that right, that would make such a difference. And thinking about what Dr. Atun was saying, we could really move the needle, right, in a big way, just if we could get the fundamentals right. It also made me think about the WHO so-called best buys in cancer care. I'm sure, most of you have heard about these recommendations from the WHO, and I think they're terrific. Because if we can get more of our energy and our resources focused on those so-called best buys, I think that's also another way of really getting some rapid improvement in cancer care, or as you say, the biggest bang for your buck, right? Thanks, Kirsty.
Thank you, Philippe. I'm conscious, Alessandro, there's a couple more questions coming through.
And just notice Rula, thanks from the Jordan Breast Cancer Program. She's had her digital hand raised for a while. Rula, would you like to ask a question?
Yes, thank you, Alessandro. I'd like to ask, actually, Philippe brought up an issue, which is the cooperation between the regulators and the healthcare about modification of the treatment regimen. Okay, now I guess it talks about less frequent visits, but more effective treatment. How did it affect the survival rate? Did we measure it in, or did some kind of a study or research to check for this effectiveness? I guess it is an important thing to talk about the effectiveness of treatment regimen modification for the purpose of checking the quality of cancer care. Another thing we need to talk about, I guess you talked about AI as well. Mostly here at Jordan Breast Cancer Program, we're a screening program. It works for the screening very beautifully, actually, but we are a low resource setting. We don't have that system. We are aware of it, but how can we use it, or use it as a resource, or how can we get the most use of it? as a low resource country. And we need to, I'd like to talk about the capacity building of the health workforce, especially those who need the hands-on training for the patient care.
Philippe, I feel like you're poised to respond, so please, please feel free to go ahead.
Thanks, Kirsty. I'll try to answer very briefly so we can get through some more questions. So thank you, Dr. Rula, for your questions. The first one was about the reduced frequency of infusions in order to help patients and reduce the visits to the hospital. Your question is important. We did conduct clinical research where we compared the lower frequency of visits to the 3-week infusion to the 6-week infusion for this particular medicine. And we did essentially a head-to-head randomized study. And what we found is that from a pharmacodynamic and PK/PD perspective, the results were the same, but also in terms of clinical outcomes, we got the same results. And so with increased dosing every 6 weeks versus the regular dose every 3 weeks, we were able to achieve the same results. And these results were presented in a medical congress at the AACR in April of this year. I'm just mentioning it because I think that the process is important, right? Whenever we develop, whenever we innovate, we have to base it on science, and we have to be very transparent about the data and the results that we obtain and share those in a public forum so that those results are available to everybody worldwide and are available, not only those attending the Congress, but the beauty of it now is that now Congresses are virtual. So you don't have to travel. Even if you don't have the budget to fly to Washington, DC for a medical Congress, you can join the Congress now and get access to all this data and all this information, regardless of where you are in the world, as long as you have an internet connection. So there is some beauty and elegance, to what has happened in the last 6 months. It's actually, I would say, democratized the access to science and the access to the latest cutting edge data. So I see it as a positive. I'll just stop there and hand it back to Kirsty because I know there's other questions.
Yes, there's a lot of questions coming up. I think what we'll do now, I'm conscious of time, we'll move to the open question exercise that Alessandro has planned. There'll be a further point for discussion on the points that come up there. So this is not the end of the conversation. Alessandro.
Thank you, Kirsty. So absolutely. So actually, we want to try to bring the audience in even more interaction. So I'm just going to quickly share my screen. So this was the previous slide. And if you're just going to quickly scroll through this, we'd like to pose another question on the same platform that we've used earlier on. And this is really, sorry, I went too far. This is really we've heard many adaptation from our expert panelists, adaptation in how we deliver treatment, adaptation in how rehabilitation is done, and how patient navigation is done. So we want to make sure that we really capture a lot that has been happening around the world and by organizations where all of you are working. So if you would like to, again, as we did before, if you still have that page on menti.com open on your smartphone or computer, the code is the same. We'd like to ask you to input in writing, how have you, as a health practitioners, as an organization, adapted during the pandemic to ensure the cancer patients can access quality cancer care and support? We've heard a few from our expert panelists, but really we want to make sure that we capture the different perspectives and the different works that have been happening, practices that have been happening around the world. And we might be calling upon some of you, some of the comments to explain further. And then based on that, we'd like to follow up with an open discussion on how many of these adaptations are actually useful to keep beyond COVID-19, but should be maintained, maybe adapted to become systemic changes, but how many of these changes are actually useful in making our cancer services more resilient and effective going forward. So just giving a few seconds, a few time to give everybody the chance to input, and maybe I'll just do a quick check-in with my colleague Sinead to see if answers are coming in, and we might want to share the Menti screen with the answers as they pop up.
Yeah, we have a few answers coming through. I'll give people a couple more minutes to get them posted. And also, if you've done more than one thing you can also share more than one time, so you can input a few answers if you wish. I'll share some of the results.
So keep them coming in as they come in. It's important that we might pick on some of them as they come. So obviously telemedicine, we discussed that quite a bit. Transition to telepsychosocial services, that's quite an interesting one. I know there's many patient support group among the audience, so it might be interesting to pick on that, how they're adapted and how the patients has actually received them. Safety measures in terms of expanding services to hospitals outside Beirut in order to minimize all travel on our kids. Mobile pharmacies, that was something that Miriam also mentioned. Kirsty, I wonder if we maybe start looking at some of the ones that we discussed a little bit less. I was wondering maybe the telepsychosocial services to see how.
Yeah, that would be great.
So maybe
we
can call upon the person who entered the transition to telepsychosocial service and describe a little bit more how that's been done and how that's been received by the patient.
Hi, Alessandro. This is Fatima from KAIF.
Hi, Fatima.
Hi. Well, for us in KAIF, we take care of children with cancer. And what we used to do was really do face-to-face counseling and child life services for our children who had cancer. So what we did was we had to group our patients into chat groups using FB, Facebook, or Viber. And our child life coordinators would get in touch with them using these chat groups. And they would, what we had to do though was to provide some allowance or funding for the internet service or even the prepaid load for our patients. And what we do with psychosocial is we would have counseling and some when we do play activities also using the digital platform. So that's how we were able to at least give the children a semblance of a normal childhood amidst COVID. Thank you.
Thank you, Fatima, and thanks for the great work you're doing. It's lovely to see you on the dialogue today. Would any of our panelists specifically like to follow up on that? Apologies, I can't see everyone on the screen at the moment. So if you would, one of the panelists would like to chip in and respond or comment further on the psychosocial aspect of cancer care, please feel free to do so.
If I may comment?
Yes, please do.
Yeah, I think that's a vital, and I think frequently we don't talk about it often enough. I think part of the challenge that we've had, at least in many parts of sub-Saharan Africa, is there's still a lot of stigma around mental health and awareness. Mm-hmm. And I think the challenge has been that we underestimate, the psychological impact of the diagnosis and just, dealing with, day-to-day concerns around the diagnosis. And what has happened initially was, again, not only was there stigma around, sort of sometimes you tell your patients, listen, I would like you to see a psychologist, and they automatically say, I don't need to see a psychologist, there's nothing wrong with me, or I don't need to get that support. And the message that we've been trying to get out to our patients is it's actually, a strength to recognize when you're struggling, and anyone, would getting this diagnosis would, typically go through the stages of grief and work your way through to acceptance. So it is a strength, but part of the challenge has also been not only the stigma, but also the cost, because there's few and far oncologists, psychologists in between, and psycho-oncologists as well. And so just even getting access to them has been a bit of a challenge. But of course, with the online, there have been quite a number of online services, not just cancer specific, but also just, people dealing with COVID. And there have been quite a number of groups that are now online, and these services are now becoming increasingly available. Patients are saying, again, even just the uncertainty around COVID and their treatment has been a considerable source of strain. And so I think it's definitely been one of those things that we should definitely try and see how can we build. I think there's an opportunity, I would say, to build a broader support. And then just because, again, in keeping with the psychosocial support, just because we used to have in-person meetings, but we've had to move those onto Zoom, and at least it's helped patients to still feel connected, continue with the support group activities, and just have that peer-to-peer support. And so I think these are concerns that we definitely need to continue to develop going forward. Thank you.
Just a quick question to follow up on Miriam and Fatima. Do you think these psychosocial support groups work as well, or could work as well as in the virtual setting as in the in-person setting? Because obviously, in receiving psychosocial support, some might say that actually the act of being with someone in person is very important. But I'd just be interested to hear if there's been any feedback from patients, given the number of times that we've talked about the patient voice and the importance of the patient voice that has come up in the patient perspective. Do you think this is something that exists just for the pandemic, or is something that we could look to take forward as a solution?
I think it's something that we definitely need to take forward. I would say part of the, of course, the challenge has been distance initially. There's, especially for us, there aren't that many support groups. So people would maybe go to the urban areas in order to access these support groups. And it's typically maybe once a month. And maybe they would continue that conversation in between by, apps like the WhatsApp. So they're already to some extent doing some form of online peer-to-peer support. So with Zoom, at least you have the added advantage, you can see people's faces. So I think people, at least in many parts of sub-Saharan Africa, are receptive to that kind of model. And then again, one of the, I guess, maybe as part of the strategies around, stigma reduction is, having a lot more open and candid conversations around this. But part of the feedback that I got from one or two of my patients is I don't have to be seen going into the, psychologist's, office. I can, just go online and have an appointment, and nobody has to know. It's my business. So, well, one would say there is that sort of privacy around that. But I mean, for sure, I think these services, what we do need to do, especially with the online model, is think creatively about how we can provide these services, because it should be it's a critical part of any cancer, treatment strategy, all the way from diagnosis to, concerns around chemotherapy, how you're dealing with those body images post-surgery. And so if we could find a way of, actively integrating these at a cost that works, for patients. And I would say this is definitely one of the things that we do need to carry forward post-pandemic.
Thank you, Miriam. Fatima, I saw that you unmuted. Did you have a final comment on that?
Yes, I think that it will be blended in a way, especially if the issue is already end of life or palliative care. I think digital or telepsychosocial would have to take a back seat when it's already end of life, or assisting the patient when it's end of life, and that we'd really have to do the extra effort to do a face-to-face, so that there will really be a quality of care for palliative and hospice care. Thank you.
Thank you for raising that important point and discussing that. Maybe, Sinead, if we stop sharing the screen now, we can then see everyone who's participating. And I just wondered if we could maybe return to the panel, but also if you have, if other people have questions or comments on the next point of the discussion. I just wondered if people would share some thoughts and perspectives on how we can, obviously in each setting, in each context, in each area of cancer control, there have been various adaptations and innovations, but I'd just like to return to one of the points we had earlier around, you know, the importance of systemic change and how we move forward in terms of, we've got all of these adaptations in different spheres of cancer control, and how do we ensure that we move forward in countries in a collective manner, and ensure that we don't continue to expand these different adaptations in a fragmented way, but together holistically. I'm not sure if any of the panelists would like to go first. Rocio, I see you're unmuted.
Yes, no, it's okay. Could you hear me?
Yes.
Yes. Okay, I think to go forward is very important to analyze, research, and build evidence with the different intervention, processes, change, and delivery. And then if we can build a good information and take some indicator, it will be good to share with other people that they are, of course, looking and working for do the better in their own context. And I think it's one is the very important issue I want to raise is the building the evidence and the information that what we are doing, how we are doing, and what is the impact. And the other thing is because we are health people, we are health workers, we are working with the people, for the people, and with the people. And for that is very important to training the people and to has some support for the new professional like we have in Costa Rica with the health promotion. There are new people, younger people that are working how to change the health system to bring the health system more building the needs or working, looking in front the needs of the population. And I think it's good to have this kind, of challenge, like a vehicle that you're driving the change. But also we need to build the information. I think this is one for me, one very important. And also, of course, use the digital records if we have. Use the information that we have storage, maybe in somewhere we have to use this information and then build the new needs for information. But if we don't use the information that we have yet, it's impossible to building next information for the new project. No, we have to use the information from the population and then look for the needs and build the new information. And of course, working together. For me, it's very important to work with the point of view of the patient, the NGOs, the health services, and all the actors that they can, support the better services for the patient cancer.
Thank you, Rocio. Philippe? Sorry, Philippe, would you like to share some perspectives on that?
Yes, thanks, Christy. I think you're right. I think that the risk we face is a fragmented approach. There's lots of great ideas out there, and we might waste a lot of energy and resources chasing, individually chasing different ideas, and I think that would end up with a very limited impact. What we need is to have some kind of consensus across different stakeholders, across all the people on this call, and all of the partners and the healthcare systems across these countries, on what are the sort of fundamentals that we need to address. And I also believe that the choices we make.
Sorry.
Oh, that's great. We have some young participants.
We do, clearly.
I also very much believe in research and data. And I think that we have to make choices that are supported by research and data. In a world where we have limited resources, and I consider our time and energy also as a resource, right? It's not just dollars, it's also our own time, our own leadership. We have to direct our leadership and our time to the investments that are going to have the most impact in an integrated fashion. And I do believe that there is research that has been done and that can support such choices. So, and then of course we have to be able to measure our progress with the right KPIs. And so I know what I'm proposing is a more kind of rational and very logical approach, but I think we have all the tools and the research to make those choices. And now it's up to us. It's up to us to move forward. If I may, Kirsty, I'd like to endorse again what I think is a great starting point, which is the WHO Best Buys in cancer care. I think that's a great example, not the only one. It's not the only one. Others have also been contributing, like Dr. Rifat and many others. But one great example is the WHO Best Buys, which I think is a terrific starting point as a checklist for investment and for directing our energy. Thank you, Kirsty.
Thank you, Philippe. Miriam?
Thanks, Christy. I think I would just underscore the comments made by both Dr. De Rocio and Philippe, just around research, but also around leveraging existing collaborations. I mean, what has happened, as I said, within this time is all of a sudden, and most of us know every 2 weeks, because again, there's an acceleration or drive around research around COVID. There's new collaborations coming up left, right, and center. I'm, in my emails getting, fill out a survey every 2 weeks around something that's COVID related by a group of either clinicians or surgeons or radiation oncologists. So it's across the spectrum. So I guess the question is, how do we then leverage these networks to see if because we already have established them, how do we then move these forward into looking at other aspects of care beyond COVID and looking at, critical aspects of, say, cancer control? And so that, for me, I believe would be a good starting off point to leverage these networks, as it were. And then also looking at, again, despite there is a clear need to have policymakers on board. And so for me, it still harks back to, yes, you have excellent research, but unless the political will is there to drive the agenda, there does need to be, I would say, lots of aspects of intervention. One, advocacy at the level of the patient, because even as we're talking about these new strategies around, telemedicine or whatever, we haven't really addressed the fact around health literacy. People can't read, can't access these. So how are we actually building these tools that are appropriate for our patients? And then how do we then get how do we then get patients or policymakers to actually endorse some of these innovations and whatever? And some of these come down to, again, still managing to educate and empower our patients, because again, somebody made a joke about how policymakers never listen to clinicians, but they will always listen to the patients. I mean, because this is the population, this is what they're saying. And so if we're able to educate, empower our populations to demand change, because even if we look at health equity and justice from a perspective, you don't have sort of like, the equity for this time is for COVID patients, and another time it's for, patients with NCDs. It's across the board, and it should be there at all times. And so we're saying, yes, the priority is COVID, but other diseases are still going on. We said, COVID's managed to stop everything else except the cancer cells. Those are still growing. And so we do need to figure out very quickly how to make sure that our voice is heard. And so part of I would say, today's is an excellent testimony to, getting political goodwill and drive, especially around cervical cancer. But now it's looking at how do we get our patient, how do we get to push? This is just, the beginning, and it's exciting, but how do we push for all cancers? How do we push for, patient empowerment, patient education, and access? And I think part of the work that the African Organization for Research and Training is trying to do is to push policymakers at the African Union and trying to see if we can lobby for some of these changes. And that's just, one example, but I'm saying there's lots of opportunities. But I mean, the fundamental bit comes down to educating, advocating, and just pushing to make change. Thank you.
Thank you, Miriam, and thank you to our excellent panelists. You've raised some really fantastic points in the discussion, and in those last few comments, I think the themes around the patient voice, the importance of collaboration. Thank you, Miriam, for raising advocacy. We hadn't discussed that here a lot, but yes, both policy focused and patient advocacy, health education, all very key points. I know we've touched on many subjects during today's virtual dialogue. I think it's good to come back to Rifat's presentation at the end, and actually those 4 pillars that he highlighted, people, both the patient and the health workforce, partnerships, collaboration, platforms, and using the research and evidence to form good policies and to engage policymakers. Yes, there's so much more we could say, but I think we are going to call it a close there. I know there's some questions we haven't been able to address. It's been a great discussion. I'd like to thank you all for participating, and I'll hand over to Alessandro for a few final last words.
Thank you, everybody, and thanks to our panelists and to our participants for this very interesting conversation. I know some of you might still be able to jump on the WHO launch of the cervical cancer global elimination strategy, so we try to finish on time. So I just wanted to, hopefully you got a lot of what you wanted to get out of these sessions in terms of learning something new and learning from around the world, the practices that are going on, and we hope certainly to see you at the third virtual dialogues in this series, which will take place on the 1st of December. And we'll discuss probably the elephant in the room. How do we make all this happen with the right resources? So how do we strengthen the case for investment in cancer control? This will take place on the 1st of December at the same time. And obviously we'll send a link around. There will be the learnings from all this conversation will be captured and will be shared with all our communities and networks through news articles and the final reports. So all this shared knowledge that's coming through in these dialogues it's not just gonna end here, but hopefully will serve to make your programs and your work easier and better. So on that note, I'd like to thanks everybody, and have a good day and have a safe journey, everybody. Good day.